Hi everyone, it's Elizabeth again, back with part 2 about enteral nutrition complications. Today we will be talking about gastrointestinal complications and metabolic complications, and then at the end we will also go over a case study. So let's get started. So now we'll move on to gastrointestinal complications. So this includes nausea and vomiting, diarrhea, constipation, and abdominal distension. I would say these are probably the complications that you'll get consulted for the most, just because, a lot of times providers, nurses will think this means the patient's not tolerating their tube feeds. So we will start with nausea and vomiting first. So some causes could be, medications. It could be an acute illness, infection. Electrolyte abnormalities can also cause some nausea and vomiting, as well as motility issues. And so when this happens, when a patient's, getting tube feeds and they're, feeling nauseous, they're vomiting, first thing we want to look at is their labs, right? We want to see, do they have any electrolyte abnormalities? Let's, provide fluids, provide electrolytes to get that back within the normal range, and then see if the patient's feeling better. Let's say their labs look great, no concerns. Next, you would want to get an abdominal x-ray just to rule out any ileus or obstruction going on that, suggests that the GI tract's just not functioning as it should at this time. Now, if the x-ray comes back and the patient does have an ileus or an obstruction, we would want to hold the tube feeds at that time until the patient starts having bowel movements or they, receive some kind of intervention for their obstruction and they have a regular functioning GI tract again. Let's say they don't have an ileus or an obstruction, then, if they're not already on an anti-nausea medication, that's when we would, recommend that they get started on one and see if that helps. If a patient's already getting anti-nausea meds and they're scheduled throughout the day and still not having any relief, then we can start seeing what we can do with the enteral nutrition regimen to see if we can improve these symptoms. So some things that you can do would be to look at concentrating the formula, and this will help provide a lower total volume of the feed. So it may just be that the patient's not tolerating how much formula they need. And so if we switch to a 1.5 or a 2 cal per milliliter formula, we can, provide a lower volume of feed while still meeting their nutrition needs. We could also see if they tolerate a fiber-free formula better. So for example, if someone has gastroparesis, they might not tolerate, fiber being in their tube feed formula and might tolerate a fiber-free formula better instead to, make sure we're not slowing down that gastric emptying even more. Lastly, what we could do is try and switch. If they were on bolus feeds, we can try them on continuous feeds just to see if they tolerate a lower volume of formula over a longer period in time instead of doing bolus feeds and potentially making that nausea worse. Let's say we've optimized their nutrition regimen, they're on a concentrated formula, we're giving continuous feeds, but the patient's still still having nausea and vomiting. Then we could see if their doctor is okay with adding a pro-motility agent like metoclopramide, which just helps promote gut motility and will help those tube feeds, move through the GI tract. Lastly, one other thing we can try and do, the patient's still having nausea, still vomiting, we can obtain small bowel access. So instead of feeding into the stomach, we can advance the tube or extend the tube into the jejunum, and then we can, be past the pyloric sphincter, so a patient's not going to reflux or vomit their tube feeds as easily as they would if we were feeding into the stomach. All right, moving on to diarrhea. This is another consult you'll probably be getting a lot with your patients on enteral nutrition. And so kind of similar to nausea and vomiting, there's a lot of different causes that could be, contributing to the symptom. Medication, certainly, again, acute illness, some kind of malabsorption. So how can we help a patient that's having diarrhea? So first step, we would want to check their medications list, see if there's any medication that could be causing loose or frequent stools. So sorbitol containing medications can be irritating to the gut and cause looser stools. So things like acetaminophen solution or any kind of medication that is in solution or an elixir typically has sorbitol added to it. And so that can cause that GI upset. Also things like laxatives or stool softeners, antibiotics, all of these can lead to diarrhea. Next, you would want to check for an infectious cause such as C. diff, because if a patient does have C. diff, we don't want to slow down the stool output. We want a patient actually to be having more frequent stools to clear out that infection. So we wouldn't want to add, Imodium or fiber to slow down stool. So let's say, a patient, did the infectious workup. They're not worried for an infectious cause of their diarrhea. So next, what you can do is, if not already getting a fiber containing formula, you can switch to getting a fiber containing formula. You could also add soluble fiber. The soluble fiber will help to bulk the stool and hopefully not have as loose of bowel movements. And then lastly, let's say you've looked at all these things, the patient's still having diarrhea, you can ask the provider to add an anti-diarrheal agent such as loperamide to help slow the patient's stool output. All right, so next up we have constipation and abdominal distension. And so this can occur if a patient is dehydrated, they're not getting adequate fluid, and that just makes it harder for us to pass stool. A patient could be getting inadequate fiber, which again just helps keep things moving. Additionally, on the inpatient side, patients are sitting in bed most of the day. They might not be moving around as much, not promoting that GI motility. And then also, if they're on narcotics can actually slow down your GI motility and cause constipation. And so what can we do for constipation or abdominal distension? Typically, if a patient's getting constipated, they might feel more bloated, might have that more distended abdomen. So how do we manage this? So first, we want to try and optimize their bowel regimen or the medications that they're getting to promote regular bowel movements. And so if they're not already on them, try and ask their provider to order a laxative or a stool softener or both. Now, if the patient is already getting these medications and still having no relief, then you could, talk to the pharmacist, talk to the doctor about ways we can, consider a more aggressive bowel regimen. So we could move towards something called a suppository or maybe an enema to, again, help promote the patient having a bowel movement. We also want to make sure, while we're making suggestions on the medication side, we also want to make sure that the patient's getting adequate free water flushes, again, just to make sure they're getting enough fluid. And then also we want to make sure we do, if it's been several days without a bowel movement, we do want to make sure that you're checking an abdominal x-ray just to, again, make sure that the patient doesn't have an ileus or an obstruction that is, the cause of this, lack of bowel movements. And then again, if, a patient has an ileus or an obstruction, we would want to hold the tube feeds and not feed the gut until normal function has resumed. Next up, we have metabolic complications. So this includes dehydration, overhydration, hyperglycemia, and then refeeding syndrome as well. So we'll start with dehydration. So again, one of those complications that's kind of more self-explanatory. It's just a patient's not getting adequate fluid. Now, there are, a couple different causes for this. It could be they're just not getting adequate flushes, but on the other side, they could just be having excessive fluid losses too. So if they're having diarrhea, vomiting for several days, if they're undergoing diuresis or fluid removal with medications, if they have a high output fistula, or if they have wounds or burns that are leaping and having a lot of loss that way, these can all contribute to dehydration. And so how can we clinically tell a patient's dehydrated? Typically, they will have a dry mouth or they'll feel thirsty. We also frequently look at their sodium level. So if a patient has a serum sodium greater than 145 milliequivalents per liter, that can be an indication of inadequate fluid intake. And then, also if a patient is reporting that they've not been urinating as frequently, that could also be a sign that they're not getting adequate fluid. So how do we take care of this? First, we just want to, again, talk with the patient and make sure that they're getting adequate free water flushes. If they're, at home, if they're on the inpatient side, checking in with the patient and their nurses, making sure that they're getting free water flushes that are appropriate. And then to help correct the dehydration, we would calculate what's called the free water deficit. So figuring out how much free water they would need to get back to that normal serum sodium range. And so you'll see over here, I have the calculation written out. So essentially what you're doing is taking where their serum sodium is right now. So let's say like it's 147, and then you divide it over a normal or your goal sodium, which is 140. You subtract 1, you multiply by their dosing weight, and then also multiply by 0.6, which accounts for 60% of the body being water. And then once you calculate through this all, you will figure out how many milliliters of water the patient would need in order to correct their sodium back to a normal within normal limits. All right, next up we have overhydration. So this can happen for, again, a few different reasons. So it could be that a patient has a chronic illness that they're not able to regulate their fluid status as one would normally be able to. So if a patient has heart failure, if they have kidney failure or liver dysfunction, they're more prone to fluid imbalance issues. Also, it could be a patient's getting IV fluids in addition to their enteral nutrition and free water flushes. And so from all these different sources, you're actually providing fluid in excess of their needs. And so how can we tell that a patient's overhydrated? Sometimes you'll see the fluid accumulation on the patient itself. So you'll see swelling in their upper extremities, their lower extremities. They might have, swelling in their ankles or their feet. You can also, again, look at their serum sodium. So if it's on the low side or less than 135 milliequivalents per liter, then that can be an indicator of fluid overload or overhydration. And so in this instance, what we can do is we'll typically start with holding free water flushes first. And then if a patient's sodium is still low, we can, utilize a concentrated formula. So switching to that 1.5 or 2 calorie per milliliter formula, just to restrict the amount of free water we're giving as much as possible. We can also just look through the medications list and make sure that the patient's not getting any additional IV fluids or any other fluid sources that can be contributing to this overhydration. Next up, we have hyperglycemia. And so for this, it could be caused by a patient having diabetes. It could also be the stress of an acute illness or injury. A patient might be on steroids for some reason. IV fluids can also have dextrose or sugar in them that can, lead to high blood sugars. Or it could be excessive carbohydrates or overall calories from their enteral nutrition. So how do we manage this issue? So first thing we want to do is make sure that we are not overfeeding the patient. So we want to make sure that their enteral nutrition regimen is not providing calories in excess of what they need. And then, if not already, we can look at putting the patient on a bolus tube feed regimen just so that their blood sugars are not consistently high throughout the day. Also, if a patient does have diabetes, it can make it easier for insulin management. So you can have, bolus insulin before their meal for their tube feeds to help, make sure that their blood sugars stay in a normal range. Another option is there are some tube feed formulas that are lower in carbohydrates, or you don't necessarily need a tube feed formula that is specific, diabetes friendly. You could just choose a formula that would provide lower carbohydrates when provided at goal. All right, next up is one that's a little bit more difficult. So refeeding syndrome. So refeeding syndrome is when you see fluid and electrolyte shifts after reintroducing nutrition. And so what's happening is that this reintroduction of sodium and carbohydrates triggers that insulin production and draws the electrolytes into the cells, so that way your serum levels are depleted. Some people that might be at risk for refeeding syndrome would be people that are malnourished, people that have not eaten well for greater than 2 weeks, anyone with a disease or disorder that impacts nutrition absorption. So, patients with Crohn's or colitis, short bowel syndrome, alcoholism. So some signs of refeeding would be hypoglycemia or low potassium, low magnesium, or low phosphorus. So how do we manage patients that are at risk for refeeding or are showing signs of refeeding? So before we even start a patient on enteral nutrition, we want to, assess and see if they have any of these risk factors, right? We want to, determine their nutritional status, if they are malnourished in some way, if they have a history of alcoholism, and then, how they've been eating over the past 2 weeks. Let's say a patient has one of these risk factors. First thing we want to do before starting enteral nutrition is looking at their labs, see if they already have any low electrolytes. So, checking their potassium, their magnesium, their phosphorus. If they are low, we would want to recommend repleting or providing extra, for example, extra potassium to get it back to its normal range. And then once, those electrolytes look a little better, then we would start the enteral nutrition at a lower rate. So either 25% of their goal or even like a trickle rate of like 20 mLs per hour for the first 24 hours, and then just monitoring their labs to see if their potassium, magnesium, phosphorus starts downtrending or becoming low. Now, let's say their electrolytes do become low again, we would again, want to make sure we are repleting those electrolytes before we further advance their tube feeds. So typically, if a patient is refeeding, it can take, a few days to slowly advance their feeds so that we're, not creating these huge electrolyte shifts. So it's a slow process. You could also look at thiamine supplementation, especially if you are concerned for a deficiency in someone that hasn't been eating well for a long period of time, or in a patient with a history of alcoholism. They're known to have lower thiamine and be thiamine deficient. So now we are going to do a practice question that will include some of the complications we've been talking about. So patient MK is a 57-year-old male with hypertension and diabetes, admitted with altered mental status and facial droop. He was found to have a stroke. A speech pathologist conducted a swallow evaluation and diagnosed the patient with dysphagia. They recommended that he remain NPO for now, so the medical team placed a nasogastric feeding tube for both nutrition and medications until the patient's swallowing function improves. So just for some background information, here are his anthropometrics, here are his estimated nutritional needs, and then here is his enteral nutrition regimen that you came up with. We want him to have a fiber-containing formula running at 60 mLs per hour over 24 hours. And then we also want him to get 240 milliliters of free water flushes 4 times a day. All right, so this patient, MK, has been receiving tube feeds at goal for about 4 days now. But now you've been consulted by his physician because he has had 3 to 4 loose bowel movements per day over the past 2 days. And so now the medical team is worried that he is not tolerating his tube feeds, and they're wondering if they need to switch up his formula or change something. So first thing we want to do, again, is check the medications list. So we want to see if this patient is getting any medications that could be causing looser, more frequent stools. So when you check the medication list, you see that this patient's actually been receiving a laxative and a stool softener both 2 times a day. And so typically patients, when they come into the hospital, they might just get started automatically on these bowel meds just to help promote them having regular bowel movements while they're here. So it is pretty common to see those medications on their medications list. So at this point, what we would do is recommend that they hold these medications for now or even discontinue since he is having loose frequent bowel movements, so he doesn't need assistance with that. Next, we would see if there's any infectious cause for the diarrhea. If the patient was, had some like infection like C. diff. So the medical team did a full infectious workup. It all came back negative, so they're not worried for an infectious cause of this diarrhea for right now. And then, our third step, remember, is to switch to a fiber-containing formula. However, we, started off providing a fiber-containing formula from the start, so it's, already taken care of. They're on a fiber-containing formula. So the big changes we made at this point is just recommending holding those laxatives and stool softeners for now, and then we'll see, if that helps improve that diarrhea. All right, so you check in 2 days later. Since those medications have been held, you notice that the patient is having less frequent bowel movements, but his stools are still on the looser side. So now we can move on to that fifth step, which is adding more soluble fiber. And so what we can do at this point is recommend adding 1 packet of psyllium fiber. Typically, you can start with 1 packet 3 times a day, kind of like breakfast, lunch, dinner, just to see if that will help with his bowel movements. All right, so again, you check in 2 days later after starting up that psyllium fiber. And now the patient is having 1 solid bowel movement per day. He appears to be tolerating his tube feeds just fine. Everything's going great. However, you do notice that his serum sodium is now 146 milliequivalents per liter. So that is actually on the high side and out of range for our usual sodium. You assess the patient. You see that his mouth is dry, his lips are dry, and then you attribute he seems dehydrated, and then you can also attribute this dehydration to him having diarrhea, looser stools for about the past 5 to 7 days or so. And so now what we want to do is we want to increase the free water flushes to help resolve this dehydration, right? So we will calculate the free water deficit. So you'll see we'll plug in his weight in kilograms, his current serum sodium over that goal of 140. So we'll run through that calculation. You'll find that he's down 2,103 milliliters or 2.1 liters basically. And so that's the total volume that we would need to give to correct that, correct his dehydration. So now that you know how much he needs, how do we figure out how to provide that volume, right? We don't want to just give, a 2-liter bolus right away. So what we can do is increase his free water flushes. Now, the important thing to remember is that the free water flushes he's already getting are to meet like his baseline hydration needs, right? And so since he's dehydrated, we want to add the water he's missing on top of the free water he already needs at baseline. So originally we were recommending he get 240 milliliters of water 4 times a day. Now we'll want to correct it over 2 days, just so we're not providing too much water at once. So we'll, divide that 2.1 liters in half. So we want to give an additional about 1 liter a day. So if we break this down into 4 times a day, it would be another 260 mLs 4 times a day. So in total, his baseline free water flushes, but plus these additional free water flushes, he would need about 500 mLs of free water 4 times a day. A little complicated, but it makes sense once you do the math yourself. So you make these recommendations, you adjust the tube feed order to reflect these increased free water flushes. Again, you check in 2 days later, since we wanted to correct that free water deficit over 2 days. Now you see that the patient's serum sodium is 141. It's in the goal range. It's great. But now you just want to make sure that you go back to his baseline free water flush needs, those 240 mLs 4 times a day, because we don't want to cause the opposite problem where we start overhydrating, right? So always important to make sure you go back to that baseline need and go back so that we're not causing any issues. So thank you so much for watching. I hope that this was helpful. If you didn't have a chance to catch part 1, you can take a look at that video. Otherwise, we'll see you next time. Thanks.